Hi guys, I'm back with a new video. This time I'm going to be talking about cardiac rhythms or cardiac dysrhythmias. Now, because there's so many, I'm going to divide them into two videos. So it's going to be a part one series of cardiac dysrhythmias and a part two. So just if you don't find the actual dysrhythmia that you're looking for or the rhythm, just go to the next video. So let's get started. Pretty much, we need to define what a normal sinus rhythm is. So a normal sinus rhythm is a heart rate between 60 to 100 beats per minute. It has P waves before any QRS. It also has a PR interval. So that's kind of an interval between the atrial and the ventricular repolarization. It has QRSs complex in every beat. It has T waves and the rhythm is regular. What all this means, I'm gonna go and explain it in just a little bit, okay? So don't worry. Now, what a dysrhythmia is, or is often called an arrhythmia, it's anything that basically is not normal sinus rhythm. Anything that doesn't follow this rule that I have listed here, it's considered a dysrhythmia or arrhythmia. These words are interchangeable, so you're going to see me, you're going to hear me refer to them in any way. So let's look at the conduction system. So we have P waves. These are always in front of every QRS, and they mean the contraction of the atrium. We have QRSs for every beat, and that means the ventricular contraction. And then we have T waves, which is basically the resting, recharging phase. Now, in order to know and understand an EKG strip, we need to look at 5 steps. Well, I call them 5 steps. You can call them either way, but I always ask myself 5 questions and perform 5 steps. You need to find out the heart rate. You need to find out what the rhythm is, if it's regular or irregular. You need to ask yourself, does my QRSs have P waves for every QRS? Or perhaps are they normal P waves? Do we have a PR interval? And is it a normal PR interval? And do I have normal QRS complex? So I'm going to walk you through each of them so you can see. So let's get started with the heart rate. So every time you want to determine the heart rate of individual, a client, you are basically counting every QRS that you see. Now, before I show you how we do this, I want to let you know that when we look at a strip, we look at 6-second strips. And then we multiply it by 10 because we know that 6 seconds multiplied by 10 gives me 60 seconds, which is a minute. So this is how we do this. We count every QRS. So we have 1, 2, 3, 4, 5, 6, 7, 8. Multiply that by 10, and my heart rate is 80. So that is how I know, if I'm just looking at a strip of 6 seconds, it's always going to be 6 seconds, that it's the heart rate is 80 for this client. Okay, the next step that you're going to do is know if it's regular or irregular. When you think about rhythm, if it's regular or irregular, think about military soldiers marching. They always march in the same speed and the same length, and so they look uniform. So the same thing with these QRSs and rhythms. So if you notice here, look at the distance between the R from the QRS complex. The R is the spike. Look at the difference between one R to the second R, the length between them, I put it in between an arrow. It's pretty much equal. From naked eye, you can see it, that it looks fairly regular. They're marching at the same time, same distance between every R. Now look at the bottom one. Do you see how from the first QRS complex to the second QRS complex to the third, the distance between them is not the same? It looks bigger and it gets bigger. Look at the 1, 2, 3, 4, 5. Between the fifth and sixth QRS, look at that big gap. That means they're not marching together and they're not regular. So this is definitely an arrhythmia, because we know that for it to be normal sinus rhythm, it has to be regular. Okay, moving on to me showing you the distance. See how it gets bigger and bigger. Look at it here. And then it gets smaller again and bigger. The next step is, do I have P waves? And there should be a P wave for every QRS. Do they occur regularly, or do we have multiple P waves and then a QRS? Do they look alike? That's the third step. The fourth step is the PR interval. The PR interval is between the initial of the P to the R, or where the QRS starts. And that should be roughly 0.12 to 0.20 seconds, or 3 to 5 small little squares. Your strips are going to come in little squares, big boxes and little squares. And in class, I'll show you how this looks like. I have examples for you. This is just an overview. Now, look at the P waves and the PR intervals example here. See how there's a P wave at the beginning of this QRS, same with this one, same with this one. However, look at the PR interval. Look how it elongates. This one, the first one is shorter. The second one gets a little longer. And third one, whoa, big, longer one. And then there's a pause there, like almost like a QRS didn't come or a beat didn't come. That's where we're looking. This is abnormal. Now let's look at the QRS complex. The QRS complex basically is the contraction of the ventricles. They're very important, and they should be less than 12 seconds on its length, or the interval between them, between 1.5 to 3 small boxes. Sometimes we have white QRSs, they're longer than 3 small boxes. So now let's look at a normal sinus rhythm. So if you notice, we have P's for every QRS. The length between every R looks about the same. Now, we're not measuring it. We're just looking at it with, in technicality, we do measure these with calipers, but just naked eye, if you're looking at it, it looks pretty regular. The QRSs look about the same size. The PR interval looks about the same size or same length. And then let's count the QRSs to know the heart rate. So we have 1, 2, 3, 4, 5, 6, and 7. 7 QRSs times 10, that gives me 70 beats per minute. So that's within what normal sinus rhythm is. So this is what normal is. This is what normal looks like. Now let's go over the cardiac dysrhythmias. So cardiac dysrhythmias are considered sinus bradycardia, sinus tachy, supraventricular tachycardia, aflutter, afibrillation, premature ventricular contractions, PVCs, and we're also going to talk about premature atrial contractions, PACs, ventricular tachycardia, and ventricular fibrillation. So let's go one by one. Sinus bradycardia, it's basically normal. It's what normal looks like, sort of. However, it's slower. It's very slower. So less than 60 beats. So you're still going to have your P's. You're still going to have your QRSs. You're still going to have your PR interval. It's still going to march about in the same distance. So it's regular, the rhythm. However, it goes lower. So if you notice this example here that I have for you, we have 1 QRS, 2, 3, and 4. We're talking about 40 beats per minute. So that's slower. That is slower than 60 beats. So therefore is sinus bradycardia. Now, this can be something sometimes normal for individuals, like people that exercise a lot, that are athletics, or maybe you're sleeping. During sleep, our heart rate slows, or maybe you are taking certain medications like beta blockers. This is normal when you are in certain medications. So let's look at the signs and symptoms. Patients with bradycardia can have perhaps hypertension if this is not normal for them, dizziness, shortness of breath. They could be a little cold and clammy. Everything has to do with low cardiac output. If I'm slowing the heart rate down, I'm not pumping that much blood. So therefore, my cardiac output decreases. So first and foremost, to treat this, you have to find out what is causing it. If this is normal for the individual because they're on a medication, or it's a side effect of the medication, you might have to stop the med because 40 beats per minute is not that ideal. However, you can give IV atropine. Atropine basically speeds up the heart and just kind of says, hey, wake up. We got to work. You can do pacing. Pacing, it's almost like a slap in the heart, like, hey, wake up. You got to keep beating for me. But we do pacing whenever the client is hemodynamically compromised, like hypertension, maybe syncope, etc. And eventually, if this is a chronic problem, they're going to need a pacemaker, which we'll talk later on the second video about what pacemakers are. But pacemakers basically just, again, throws an electricity at the heart saying, wake up. So for sinus tachycardia, you still have all your QRSs, you still have Ps, the PR interval, it's the same for every QRS. Your rhythm is regular. They march at the same distance. However, it's going fast. It's going above 100 beats per minute. So if we count the example that we have here, let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. Multiplied by 10, that means 130 beats. That's going fast. Now, this could also be normal to some people. For example, someone that has fever, someone that is on going through a lot of stress, someone that maybe got scared and it's in fear, or maybe there's an underlying disease going on. For example, anemia. On my anemia or my blood disorder video, I said that anemia can cause tachycardia. Or maybe this is because you had a Red Bull and now you have full of caffeine and you're excited, or maybe you're doing drugs. So these could be results, could be expected for some individuals. Then another thing is signs, what the signs and symptoms are. So pretty much they could have dizziness, they could have palpitations, chest pain sometimes, shortness of breath, but it all has to do and goes back to low cardiac output. If my heart is pumping really, really, really fast, it doesn't allow time for my ventricles to fill with enough blood to pump to the rest of the body. So again, cardiac output is compromised. So what we do for these individuals is you got to find out what's causing it and try to fix it. So if it's fever, let's bring the fever down. If it's a panic attack, let's calm them down. If it's stress, well, we got to control our stress. If it's exercise because you're running, your heart rate will come down after a little bit. However, if it's none of these and it's just randomly happen, you can do vagal maneuvers, which is like bearing down or coughing, etc. Or you can give them medications such as beta blockers intravenous, like metoprolol, that slows the heart rate down. They could also receive calcium channel blockers like dialtazem. And in worst case scenarios where the patient is hemodynamically compromised, then we do synchronized cardioversion. Now, synchronized cardioversion is going to be on video too. We'll talk about what that is later. Now, there is something called supraventricular tachycardia. And basically, this is when the heart's electricity system malfunctions and it goes extremely high. And we're talking 160, 180, 200, 220 beats per minute. And it happens so fast. So if you notice, the QRSs look a little different than the previous ones. If you need to rewind the video, you can. Anyways, some of the causes that can cause supraventricular tachycardia, we also say SVT, it's caffeine, stress, especially Monsters or Red Bulls or those 5-hour energy, especially when those came out and people started using them, we saw a lot of these clients in the emergency room. It could also be caused by heart failure or toxicity to digital medications. The signs and symptoms are the same: palpitation, chest pain, dyspnea, hypertension, but because again, it has to do with low cardiac output. The treatment is vagal maneuver, but the drug of choice here is adenosine, which is an antiarrhythmic medication, adenosine. Adenosine has to be pushed. It's the only drug that I could think of right now that is pushed fast. And it basically, we push it in less than 2 seconds, and then we follow it very quickly with 20 mLs of normal saline. And it literally stops your heart and resets your heart again. So it's a wonderful drug for these individuals. Yes, they can have metoprolol, calcium channel blockers, and cardioversion, but the drug of choice, the first one, is going to be adenosine. Now, if adenosine doesn't work, then they might go into cardioversion if the patient is unstable, or try the other drugs as well. The next is atrial flutter. So pretty much here, these are atrial or atrium dysrhythmias. It basically originates from a single ectopic focus in the right atrium. It's the second most common arrhythmia. And if you notice here on the diagram of the drawing of it, we identify it because they look like sawtooth shape waves. So there's a bunch of basically sawtooth right in front of a QRS, and there are multiple ones. That means my atriums are basically going really fast, and it picks it up like that. Some of the causes could be just age, coronary artery disease, lung disease, heart failure, and some medications. The signs and symptoms: palpitation, shortness of breath. If you notice, they keep repeating. Um, but the problem with this, or our concern with a flutter, is the risk for stroke. Not only heart failure, but also stroke due to clots. And so, because the atriums are not pumping adequately in a flutter and a fib, which I'm going to talk next, the blood kind of pools and they could develop clots that can then be pushed out to anywhere in the body. We could be the lungs, um, the brain, etc. So the treatments for this is that we're going to do calcium channel blockers like dialtazem or beta blockers. We can also give them antiarrhythmias, amiodarone, that converts basically the flutter. And sometimes they do require an ablation, which is like burning that irritating spot in the atrium to convert them back. Sometimes also they could do cardioversion, electrocardioversion. The next is atrial fibrillation, or we say atrial fib. Basically, here is very disorganized atrial electricity because of multiple ectopic focus. So pretty much here we call the atriums are quivering. They're like that. And that's why you don't see the sawtooth, you see wiggly lines, okay, or wiggly waves, because they're going really, really fast. Some of the causes are coronary artery disease, heart failure, alcohol, caffeine, electrolytes. Sometimes surgery can cause it. And the signs and symptoms could be palpitations. It could be an irregular pulse. Like if you take the pulse of the patient, you can see that it's like skipping. Dizziness, lightheadedness, again, goes back to cardio output. And however, some people could be in atrial fibrillation and not even notice. I had a physician that I work with that this happened to. The medical treatments are, first of all, we got to control the rate because it's going too fast on the atriums, and we can give digoxin, okay? We can give beta blockers like metoprolol, calcium channel blockers, or amiodarone. They need to be on a anticoagulant or antithrombotic therapy, same as a flutter, to prevent clot because they're at high risk for clots. And also forever, they can, to basically fix it forever, they can have an ablation, again, burning that little tissue that is irritated in the heart so that it doesn't happen again. Okay, well, I'm going to continue the next dysrhythmias in a different video, just so that way it's not so overwhelming. And I'll see you on the next one. And as always, my reference are the book and Google for the images. I'll see you in the next video. Bye-bye.